anterior approach or posterior approach from the Cobb angle proximally to the Cobb angle distally. Everyone knows that. And whether done from the back, as you can see here with sublaminar wires, or done from the front by the Kaneda technique that was developed and perfected in Japan and taught all over the world. And Dr. Kaneda and Dr. Zilke are some of my most important mentors. Dr. Zilke, I operated in Louisville when I was there, when I was maybe 32 years old. I had a party for him for my house. He's a master surgeon. I've never seen a surgeon who could operate so beautifully, so fast. He's an incredible technician, like Professor Kaneda, who is a mentor for me. The bone-on-bone technique builds on what they taught me. And I gave that back to them as the president because I honor them so much. And it uses instrumentation so you can get the same result with about instrumentation of half the levels. So that short of the fusion, it's been proven by many papers in the literature that the patient's function, that is in working, in leisure time life, in sports, in athletics, the shorter the fusion, the better the function. Dan Succato in Texas, Baron Warner, who is taught some Thai surgeons, and Linda DeAndrea have all shown that beautifully with prospective trials and bulletproof information. So short fusions functionally are better for patients, although it takes more talented surgeons to do this kind of work. So here's a 12-year-old little girl with a thoracic curve, Linky 1. That's a 58-degree curve. She's premenarchal, Rissa 0, and a 58-degree curve. So at least in the United States, most people these days, and I think in Thailand too, somebody told me, will do posterior only instrumentation from T6 to L2. Then that's 9 vertebra, 8 discs. 9 vertebra, 8 discs. And she'll be stiff. But this little girl's an athlete. She's a dancer, and you can see here how flexible she is. She's doing cartwheels. So this is, if her back is stiff, she can't do cartwheels, at least in the area of this instrument. Here's the stretch film. I talked to you about this yesterday in the talk about spondyloptosis. I can't tell you how important it is, fundamental in my practice, and I advise that it's a very effective way to identify clearly the Cobb angle on the stretch film, which here, the Cobb angle is from T8 to T12, and that's 21 degrees. So 58 goes to 21. It's a very flexible curve. This is ideal for bone-on-bone. Ideal for it. So here she is preoperatively, 58. Here she is almost straight, 8 weeks post-op. You can see the improvement. See the incision here under her shoulder blade. Pre-op sagittal plane is better. Wasn't bad before. And here it is, 58 to 21 with 5 vertebra, 4 discs. And so she's still athletic. That's what she wants, and her mother likes it as well. So this series is the first 45 consecutive cases that were done by me from 1996 to 2002. The mean follow-up is is 72 months, 6 years follow-up. The slowest was over 2 years, 28 months. The longest was 121 months, which is 6 years. The mean age 19, from 9 to 51 years. There were 6 males and 39 females in the entire series. We didn't lose anyone to follow-up. We followed every case. And this is the first 45 cases I ever did in my entire life. So this is the learning curve for bone-on-bone. There are 28 thoracic curves, that is Linky 1. The mean age was 18, 24 females, 4 males. The mean operated levels was 4.5 levels. So we did 4 or 5 levels operated in the Linky 1 cases. And here's this girl pre-op. Here she is post-op. I'll show you her slides again. There's the incision. Here's a boy, 51-degree curve, 38 degrees on stretch film. And here he's instrumented 5 vertebra, 4 discs, 51 to 26. So this is 5 vertebral levels when he would have had 9 or 10 vertebra instrumented from posterior. 23 degrees of sagittal plane alignment through the area of the curve that will be instrumented, and post-operatively it's better down to 39 degrees, up to 39 degrees, which is more normal, not hypokyphosis, but normalize the kyphosis. In addition to correcting the scoliosis, here it's flat, and here it's better. And here's the patient pre-op. You can see his scoliosis here, uneven shoulders. Here now they're even. Here's the incision, and here he is bending forward. And this is 3 years between pre-op here, 3 years, and post-op here. You can see the change in improvement in his rib cage, 3 years apart. There were 17 thoracolumbar curves, Linky 5s, in this lumbar primaries. Mean age was 21, 15 girls, 2 boys. The mean instrumented levels was 3.2, so either 3 or 4 levels in these lumbar cases. And here's this girl post-op. You can see the uneven shoulder, the uneven waist, and the pre-op photograph, the normalized waistline post-op. The indication for surgery is a single major curve less than 85 degrees that is more than 50% flexible on the stretch film. So you've got to learn how to do the stretch film, and it's as easy as taking a breath. You just pull on the patient, don't scare them, relax, pull on them, and then you take an x-ray, lying down. It's easy. Compensatory curves must be less than 50 degrees and greater than 50% flexible. So huge rigid curves over 85 degrees are not eligible for bone-on-bone. They're too bad. So this is for cases that are identified from school screening, not for the horrible curves that come in occasionally. The contraindication is what is shown in these 2 slides. Abnormal pulmonary function test because of severe thoracic lordosis. Severe thoracic lordosis. Because the thoracotomy will make those patients' lung functions worse. So don't do this in severe scoliosis or patients with severe thoracic lordosis. This is how to do the stretch film. This is Bill and Flo, my 2 nurses, stretching one of our x-ray techs. Just lay them down on the table. Relax. Honey, we're not going to hurt you. But we are going to pull on you now, so just relax. We won't hurt you. Don't be violent. You don't have to be violent. Just pull firmly. All right, relax. Shoot. Relax. Takes 10 seconds, maybe 4 minutes to do the entire thing. And this is, here it is before the stretch. Here it is after the stretch. The patient is imbalanced. You can see what's going to happen when you straighten the apex. So the stretch film is much better than bending films. It takes half the radiation exposure, and it puts the patient in a situation where you'll see what the alignment's going to be like when you're done. So I can't tell you how important this is, and it makes things easier for you, not harder. So here's 53 in this particular patient, 53 degrees lying down, standing up, goes to 26. So we're going to operate on the Cobb angle on the stretch film. That film identifies clearly the levels that need to be instrumented. The Cobb angle on the stretch film. It's as easy as taking a breath. Now, the total discectomy is the key to getting bone-on-bone apposition so you can get the spine straight. You must take not some of the disc out, but all of it. Every cell. All of it's got to come out. And this is Joan Mehta. We're going to show you some movies here now of him doing the case. He was a fellow at the time, and he's now a professor at Birmingham Children's Hospital in Birmingham, England. And, excuse me, you'll see him first thing we're going to do is remove the head of the rib, the portion that attaches right next to the foramen. At all the levels we're going to instrument, from T10 or in the levels we're going to instrument, and before we put the implants on or take the discs out. So that we have to see, this is the photograph. The dural tube is right here. You can see it. The posterior longitudinal ligament is right there. This entire disc has been removed. And the nerve root is back here. You can see that. Nerve root is right there. And you've got to get into the canal. You have to be very careful because you can damage the spinal cord clearly and the dural tube. So this takes a surgical practice, but it's something you can practice in the cadaver lab easily. So here's drawn, you're using a sagittal saw to amputate. You see the head of the rib right here. That's T11. Amputating the head of the rib. Careful, careful, careful. Notice there's no bleeding going on here at all. None. Zero. So you just have to go slow, be careful. If you want to have a thoracic surgeon do the approach, I can do the own approach myself, but thoracic surgeons can help you. If you don't want to do the approach, use a thoracic surgeon. They get used to it. They may or not get paid for it, and at least in the States. And so it makes it easier. They can open and close for you if you want. And I think that's, and they can also do all this rib head resection if you don't want to do that. We have 4 great thoracic surgeons in Columbia. Okay. Then once the rib head is out, then you want to find the intervertebral foramen and identify the exiting nerve root. Just see it. And here we're using a gold tip rongeur that are easy to purchase from DePuy or other manufacturers. That is a stout instrument because we're removing osteophyte around the rib head. And then we're going to open the intervertebral foramen with Kerrison's, just like doing laminectomy, in order to open up their intervertebral foramen so we can put a pin field into the canal in front of the dural tube to protect it and identify the posterior aspect of the intervertebral disc at each of the 3 or 4 or 5 levels that we're going to instrument. So here you can see Juan, he's using a curette now, long-handled curette, to gain entrance into the intervertebral foramen, get into the intervertebral foramen once he's identified it, and then we're going to open the intervertebral foramen with a Kerrison, just like doing a laminectomy. Here's the curette again. And here's the Kerrison, just like doing a laminectomy. Here's the Kerrison, and we're opening up, making the intervertebral foramen from a little one like this, tight, 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 and opening it up, getting it bigger, so you can get a pin field into the spinal canal, all the way across the spine, and then you can know where the posterior aspect of the disc is, so you can take the posterior annulus out. I'll show you that just in a second. 2 or 3 cases by a committed surgeon is all you need to do this, and I've taught at least 50 young residents, second-year residents, first-year residents, how to do this. It is not much harder than having lunch. Once you just go carefully, this is easy to do. Somebot has done, I don't know how many of these cases Somebot has done, but he's done, I hope he's done a lot of them. And he's a great surgeon, and I think that's, and Cern can do it. All my fellows, we Charn can do thousands of these. And Soccer could do them beautifully. And Chattapon. So we're just going slow, taking time. This process maybe takes 45 minutes or something like that. No rush. Oh, good. These movies are playing beautifully. That's great. And here's the curette going into the canal. You can see now it's easier for him to get in. He doesn't have to work hard at it. Here's the pin field. And this goes, the patient's lying straight on their side. So this goes from straight down toward the floor. gel foam right into the canal and wait. Go work on another level, let it clot, and come back to that level after you're done. So you've got to be real careful here. This is careful, but you can easily master this technique. It is important that you do it carefully. Okay, great. Now here's, after the frame is open, here half of the disc, or maybe 2/3 of it, is gone. That's the easy part. Once you're into the canal, then taking the disc out, find the end plate, and use the gold tip rongeurs. And here's this dural tube. You can see it. There's the pin field. Here's a little bit of disc, and there's going to be the posterior longitudinal ligament will come into play right there. Right here. You'll see it in just a minute. Just keep going, because all the disc has to come on. Every bit. And you see now how the disc space is coming closed? As it gets closed, as you get the disc out, the spine starts correcting itself. Because the patient's lying on their side, and it starts coming together. So it makes it a little harder. Here's the dural tube. You can see it. And there's the posterior longitudinal ligament right there. You see a white stripe. Maybe you can see it, maybe you can't. I'll give you a copy of this movie if you want one. They're easy to get. I'll give me a flash drive. And here's now we've got 5 vertebra, 4 discs, and 1, 2, 3, 4 discs are out. The spine is almost straight, and there are no implants because you've taken the entire disc out. So now this is just like fracture fixation. This is the cast system. You can use any system you want, but put the screws in the vertebral bodies, and now the epidural catheter insertion is great for pain control. Somebody's an expert at this. You put the epidural catheter in the frame and then infuse morphine and intrathecal morphine. And then you're going to see in a few minutes, you're going to see the famous Kuhn-Korn-Salot maneuver. That's when we attach the epidural catheter onto the hub. And we named that after somebody. We still use it. See, there's still almost no bleeding. There comes the needle, hollow needle, to a tweed needle, and then thread the catheter into the needle, comes out the other end, pull it through the skin. Careful, not too much. And here comes the famous Kuhn-Korn-Salot maneuver. There's it right there. And then you hook that up to the IV that infuses the morphine into the epidural space. And we've never had a dural leak. And then use a little piece of gel foam. That's how you do it. And then we used to close with a Gore-Tex to replace the pleura. That isn't essential, but it's a nice thing that someone suggested. We did probably 20 cases with that. And just to protect the lung from the surgical implants. So here's pre-op, about 60-degree curve. There she is, 5 vertebra, 5 vertebra, 4 discs. And here's the implants. You see this disc has already fallen into bone-on-bone apposition and then no implants, just because you get the disc all the way out. Right here, I have to do a little bit more work to get this bone-on-bone. This is already touching and there are no implants. This one I have to do a little bit more work. And after doing that work, then you put the implants in, you put the first rod in, do all the correction with the first rod, tighten the screws up in the caps, and then put the second rod in. No additional correction at all. It's just for stabilization, for rotational stabilization. So here's bone on bone, and bone on bone like this is okay, like this is okay, like this is okay, like this is okay. So as long as you've got one side touching, it doesn't have to be extremely perfect. You just have to have contact so you can get healing and compression, and that straightens it out. So here's the operative time is about 5 hours, 6 hours in both the thoracic and Linky 1 and Linky 5. Blood loss was 800 or 900 cc's. Hospital stay was about a week. Number of levels operated was 4.5 in the thoracic cases and 3.2 in the lumbar cases. Time to fusion was about 10 weeks to get obvious consolidation. These healed like a wrist fracture in a teenager very quickly. So here's just a few cases. Here's 53 to 28. Common angle, I'll go to a little bit quickly. Here's the tilt angle correction, 28 to 8. Here's the sagittal plane correction, 14 to 24, getting better. And in the sagittal correction in the lumbar cases, 5.6 to 4.8, no change. If you need to use an interbody cage for lordosis, use it. If you want to create flat back by getting bone on bone, use bone on cage. And we do shoulder inference kyphosis. I don't have time to show you that for easy cases. We had 2 cases of atelectasis, 3 UTIs, 2 patients with rib area numbness, no readmissions in any case for anything. And no non-unions, no loss of correction, union seen in 2 or 3 months in every patient, back to unrestricted lifestyle in 3 months. So no neurological problems, no vascular problems, no deep infections, no deaths, no DVT, no PE, no mechanical problems at all, no non-unions, no loose implants, no broken implants, no junction problems, nothing. None. Good results. They're happy patients, live in Missouri, they're my neighbors, and one unplanned reoperation for complication in a bone-on-bone patient, 15 years, 160 cases. No adding on in the past 160 cases over the past 15 years, and I live in Columbia, and these are my neighbors that are operating on. So if there was a problem, I would know about it. And this is in southern Poland, in Zakopane, Poland. This is Dr. Zarzicki, the chief of orthopedics there. I showed this about 15 years ago, and he's done, that's Dr. Zarzicki and me in the inset. That's his hospital. Over 1,000 cases with bone-on-bone in 5 years. He's published this. So I think from my standpoint, it's not only yours truly that can do this, and he does it with a single rod implant, single screw, single rod. And he gets bone on bone, and these are not experienced surgeons doing these cases. These are entry-level young faculty members who are 30 years old or 32 years old. I went there, I've been there 3 times, operated there, and they're entry-level people, not senior-level people doing these cases. So this is not here's Hilali Nordine and I went at Royal National Orthopedic Hospital that does 3/4 of the orthopedic surgery, scoliosis surgery in Stanmore in London, with his young team, doing a case 73 to almost straight, 5 vertebra, 4 discs. This is a 2009 15-year-old child, and K2 implant. And so we've done many centers in the United States use it. Poland, I told you about Zurich. Con Min is a master scoliosis surgeon. Zurich uses the technique, has done hundreds of cases, much better than I have. In Ukraine, there's a paper on this in Russian. There's a center in Kharkov, Ukraine, which has done 50 or 75 or 100 cases published in Russian. It's been done in Royal National, I showed you that. Colombia, South America, in Bogota, in Australia, all over Australia, Singapore, Japan. Many people have used it. Now in China, in Beijing and Nanjing, all about it. So many fewer levels, many fewer complications, at least in my hands. And there's my email address, rwgainesjrmd@gmail.com. Please use it. Appreciate it. Thanks very much.
Thank you very much for your world-class lecture. And thank you for your sharing your experience in your life. And actually, I think the entry procedure for correction process get more advantage. Your segment fusion is a global segment, and do not need only neuro monitoring and no lumbar decompensation problem Thank you again, Dr. James.